Welcome to the second episode of Striking a Balance Between Effectiveness and Heart Health. In this episode, we're tackling a key concern in CLL treatment, the cardiovascular risks associated with BTK inhibitors. Listen as Anisita Fadal, PhD, APRN, from MD Anderson Cancer Center, and Lisa Nodzon, PhD, APRN, from Moffitt Cancer Center, two distinguished experts in hematology and oncology nursing, share their perspectives on how different inhibitors compare in terms of cardiovascular safety, examine the latest clinical data, and discuss why individualized patient assessments are crucial for reducing complications.
Hello, I'm Anisita Fadal, and I'm joined today by my esteemed colleague, Lisa Nodzon. We now know that BTK inhibitors are effective in the treatment of CLL, as evidenced by findings from clinical trials. At this time, we are also aware that there are potential adverse cardiovascular effects. So, Lisa, can you discuss with us what are the cardiovascular risk profiles associated with BTK inhibitors?
Yeah, some of the most common ones of clinical interest that we think about are hypertension, atrial fibrillation, as well as bleeding events.
So, can you discuss, each of these BTK inhibitors and the potential cardiovascular um, adverse events associated with each of them?
Yeah, first we'll talk about ibrutinib. This was our first generation BTK inhibitor. In clinical trials, including Resonate as well as Resonate 2, cardiovascular toxicity profiles begin to emerge with this particular agent, whereas we saw atrial fibrillation in around 6 to 10% of the patients, and hypertension occurred at up to about 14%, as well as some of the bleeding events, most of which were low-grade bleeding events, but nonetheless can happen as many as 44% of the patients. Now, of course, these side effects are believed to be due to the off-target effects of BTK, and particularly hitting EGFR or the TEC family of kinases that contribute to the toxicity profile here. As such, ibrutinib may pose greater risk for certain individuals on that agent, whereas now we have the second-generation BTK inhibitors, acalabrutinib and zanubrutinib, whereas they've been shown to have less cardiovascular risk profiles. So they're kind of the more mainstay of therapies that we use nowadays when it comes to CLL management. And the Elevate trial in the front line, as well as in the Ascend clinical trial, acalabrutinib was associated with much lower rates of atrial fibrillation, around 3 to 4% of the patients compared to ibrutinib. And that matched similarly in the Alpine trial. Zanubrutinib was associated with around 2.5% incidence of AFib. So you can see that this is much lower compared to ibrutinib at 10%. So again, we tend to have a favorable safety profile for the second-generation BTK inhibitors. Of course, these findings we believe are attributed to higher fidelity of the BTK inhibitor for the target and less of the off-target inhibition. So we prefer these, particularly in our elderly patients with CLL, as the median age of diagnosis is 65 and up, where they tend to have cardiovascular risk to begin with. Now, of course, we do have real-world data as well to further support our reduced cardiovascular toxicity profiles of the second-generation BTK inhibitors. In the Elevate trial for relapse refractory CLL, acalabrutinib, although being shown to be non-inferior to ibrutinib, but this was a very important trial looking at head-to-head data now between acalabrutinib and ibrutinib. And what they saw in this particular trial was obviously significantly lower rates of the AFib as well as the hypertension. So again, suggesting a more favorable safety profile. And then likewise, as I mentioned earlier for zanubrutinib, of course, we do not have head-to-head data in clinical trials with acalabrutinib and zanubrutinib. So everything we do between these two BTK inhibitors is more about inference between the two. But again, I think the most important thing here is just establishing an understanding with the patient surrounding the different effects that they may experience, and then managing and educating accordingly. And we have a newer BTK inhibitor on the market called pirtobrutinib. This one is different in that it is a non-covalent BTK inhibitor. So we have been using it more so in the patient population where they develop resistance to the BTK inhibitors, second generation in particularly, which those inhibitors bind covalently. So this is a different type of binding altogether, but nonetheless the same class of drug. So that can be a bit confusing for some patients. But it's shown so far to have a very favorable cardiovascular safety profile. Of course, we have to remember if the patient's coming from a second generation BTK inhibitor and switching over to pirtobrutinib, is anything being carried over? So that's going to be an important teaching point as well too. But nonetheless, in the clinical trials with pirtobrutinib shown very favorable cardiovascular safety profile, and particularly with hypertension around 14% and lower rates of AFib at around almost 4%. Of course, the incidence of grade 3 or higher adverse events is low, but nonetheless very important to still be monitoring out for them. And of course, time will tell with this drug across the landscape here as we use it more, if there's going to be anything new developing. But I think at the end of the day, again, these are all BTK inhibitors, and their patients are always going to be at risk for bleeding while they're on these particular agents, and the risk for hypertension will be there as well. So that's always something to bear in mind, even though you're using the different agents.
Thank you, Lisa, for that comprehensive discussion of the cardiovascular risk profiles of the different BTKs. So, what are the strategies for nurses to identify, manage, and monitor these issues?
Yeah, so of course, atrial fibrillation can be a very scary thing when patients hear it, in terms of the education that we give them prior to starting these agents. But for any patient that we're getting ready to start out on one of these agents, if they have a history of atrial fibrillation or they don't, we do educate accordingly. If they have a history, they could be more likely to develop atrial fibrillation again. So we like to find out, do they already have a cardiologist perhaps that they're working with? If not, we do like to establish one for that collaboration of care with cardiology or cardio-oncology. And it's really important then, once the patient starts the agent, for us to be cognizant of the fact, do they have any other comorbid issues that could contribute, such as hypertension. Obviously, age greater than 65 further contributes to their risk. The CHA2DS2-VASc score is important because, as I mentioned earlier, the bleeding risk can be there with these patients from the BTK inhibitors. So are they already on an antiplatelet? Are they already on an anticoagulant? And then, of course, from the nursing perspective, what's really important is that they're typically the ones triaging the phone calls. So for any patient calling in with shortness of breath, any chest discomfort, or any dizziness, that needs to be further worked up. And those are the patients that we do need to be seeing in clinic, or perhaps sending them to the emergency room if there's a concern that that patient's back in atrial fibrillation again based on their history. Hypertension is another one that does merit a lot of attention to. Why? It is the one adverse event for BTK inhibitors that is a late onset side effect. So whereas we tend to think these things occur early in the game, that's not the case with hypertension. So for patients that are coming into the drug, do they have a history of hypertension? Is it controlled? Are they on the appropriate medications? Do they have a cardiologist? Is it primary care? So profile around that patient is going to be an important consideration. Keeping a blood pressure diary log is going to be very important as well too. And then letting the patient understand, why do we need to do these things? And really writing things down allows for whether you're an APP or an RN to kind of see these serial trends in time. And I tell patients too as well, take the blood pressure at least 3 times a day in the beginning, or if you're around an event, you're having more headaches, let's say, that could be an indicator as well. Of course, when we're thinking about APPs and what do I do? I've got a patient that's coming in, they've got hypertension. What should I do? Well, to start them off, if they don't already have a cardiologist, considerations could be an ACE inhibitor or an ARB or hydrochlorothiazide to begin the patient with, to see if that works. And I would recommend, if it gets more complicated than that, maybe the patient's not responding, to definitely seek collaboration with cardio-oncology or cardiology. But I think this is a nice assessment for RNs every time they're seeing these patients, also to be reviewing the blood pressure diary log with them. Bleeding risks. This is a really important one because this risk is always going to be present as long as the patient is on the drug. And that's a really important consideration when we're starting patients out. Some of the things that we do to profile our patients is we want to know any history of bleeding disorders. What sort of medications are you on? Are you already on the antiplatelet? Are you already on the anticoagulant? Perhaps their platelets are low for starting off, and that's increasing their risk as well. one of the biggest teaching points we have to provide as APPs, as well as an RN to the patient, is the risks surrounding surgeries. If the patient is going for any kind of surgical procedure, whether it be a cardiac cath, a dental extraction, or just some skin cancer removal, there's going to be a difference in how long we need to hold the agent. I'd say for simple procedures, a skin excision, maybe with a skin cancer, 3 days, but cardiac cath, hip replacements, you're going to want to hold much longer. I think here the problem sometimes with patients is, well, my platelets count looks normal, but that's not has nothing to do with platelets. It's just the off-target inhibition that's important for platelet aggregation. So when these patients come in, assessment in the clinic, we look for the bruising on the arms, any big hematomas, any recent falls. That's going to be really important. Of course, we always worry about our patients falling, particularly in this particular age group. And then other precautions as well, just surrounding the bleeding and the bruising. When to call us, what's important if you're seeing any particular bleeding, what you should not be. And then drug-to-drug interactions, I think, for the final teach-home point here, why these drugs come from the specialty pharmacy. And we know that the specialty pharmacy may not be up to date with all the other medications that the patient is taking. And we know that there's a very serious drug interaction between the strong CYP3A inhibitors. And oftentimes, these are the cardiac medications that can interact with the BTK inhibitors. So accurate drug list is very important. And anytime the patient gets on a new agent, I advise them to contact the dispensing pharmacist to find out, are there any potential drug-to-drug interactions that could change the bioavailability of the agent either way. So it's important when the patients are coming in that the nurses are getting an up-to-date med reconciliation. And then, of course, under drug interactions, we have to educate on the use of supplements, as we know there's certain ones, like vitamin E, for example, that can also increase the patient's bleeding risk.
Thank you. Um, yeah, thank you for the extensive discussion in terms of these cardiovascular risk profiles. And can you give us a little differentiation, or some differentiation on what an APP should do versus what a nurse should do in terms of the strategies to minimize cardiovascular adverse effects during BTK inhibitor therapy?
Yeah, so one of the big things that we do, so me being a nurse practitioner, when I'm with the patient trying to strategize the risk, is when we first start the patient out on the agent. Of course, we provide a lot of patient education. This is how the drug works. These are the big things that we're looking for as we review those cardiovascular toxicities we just spoke about, and then making sure the patient has enough education before they leave the clinic. And then I think what's important for the nursing, and because again, they're the ones that are typically seeing the patient, whether they're being in their infusion center or they're triaging the calls or the patient's coming back to clinic and checking in, would be for just a review once again with the patient. These are the side effects. Are you experiencing bleeding? Are you experiencing bruising? Any new medications? It's going to be important, right, to update the med reconciliation. And then for if the patients are calling in, I'm having bleeding, or I'm having dizziness, or my little chest discomfort, I feel palpitations. That typically can be a big one over the phone. Those are conditions that would concern us for, is there something cardiovascular going on? And then the RN can inform the APP, and we can bring that patient into clinic for further evaluation.
Thank you. And we all know that managing these patients, we are not operating in silos, but we work with interdisciplinary teams. So, can you tell us, the different strategies that APPs and nursing or RNs could do to collaborate with the interdisciplinary teams to mitigate the risks in BTK inhibitors?
Yeah, I think collaboration is really, really important, as we can't be masters of everything, right? And we're so focused on their CLL their hematologic malignancy. Um, we tend to have some blinders on. So for our patients, as an APP, when I start them out on a BTK inhibitor, I'd like to find out what is their cardiology background. Do they have one? If they do not have a cardiologist, I will refer them over to our cardio-oncologist to establish care, to get that baseline assessment as well as some ongoing monitoring. And then our RNs also like to do printouts of education for the patient. They can print out the blood pressure diaries as well too, to help liaison between us and the cardiology team. That's really important. Is the patient maybe will be more formal with writing down their blood pressures if you give them more of a diary format. And then the RN can also help facilitate if a patient's calling in and, they're experiencing some cardiotoxicities, to just establish that line of communication. And in our particular case, an email would be generated amongst the team members talking about the patient that called in and what symptoms they're having, because through that line of communication, we could perhaps can start the workup maybe on our end before they go see the cardiologist, or the cardiologist can say from their perspective, no, I'll see the patient, I'll start the workup. Because I think obviously having a delay, if we could order the EKG before they're seeing the cardiologist, is important. So again, I think just as long as that team is communicating, it's in the best interest for the patient overall.
Yeah, very good. And, like this are very important information in terms of the management of these patients, and you discuss the role of the AVPs and the RNs. So, Lisa, thank you for that wonderful information. How is this information applicable in practice?
Yeah. So, for example, let's take a patient. Let's take a 64-year-old female. And let's say that she has no cardiovascular complications, and she's been on a calibrutinib, or sort of should I say, no history of cardiovascular complications, and she's been on a calibrutinib now for, let's say, going on 5 years. She's doing beautiful from a CLL standpoint. However, she comes into clinic, we look at the blood pressure diary, and we begin to notice a serial trend over time that's very consistent with the development of hypertension. So this is a patient now that we recognize is experiencing a cardiotoxicity on a calibrutinib, and we definitely have to do an intervention here based on her blood pressure readings. So we may consider different antihypertensives for the patient to start on. I also think an important point at this time as well is to collaborate with cardiology or cardio-oncology with this patient, just for hypertension management. Things that we could do on our side and the RN could also help us with is talk about dietary modifications as well too. In a patient like this, because why? Now we have hypertension, and again, being on a calibrutinib, we think about the chronicity of indefinite therapy. So this is a patient that'll start on an antihypertensive and unlikely to have to discontinue that because they're still on the medication.
Wonderful. So, can you give us like 2 or 3 key takeaways that we will need to keep in mind when we are managing these patients who are treated with BTK inhibitors?
Sure. So I think the data has been showing and speaks for itself that the second generation BTK inhibitors, such as acalabrutinib and zanubrutinib, and then our newest comer on the market, pirtobrutinib, have much less cardiotoxicities as compared to our first generation ibrutinib. The patients do wonderful on it with great efficacy, but important to pick the right drug for the right patient, right? We're really good at being able to profile them. I think another really important one is to consider when we are profiling our patient, the level of education that we need to give to the patients as well for safety, right? These are oral drugs. These patients take them from home, so we're not there to monitor them. So the education surrounding the profiling and the drug interactions for that particular patient will be important. And I think lastly, one of the biggest contributors that we can do is collaborate with our colleagues for these patients, getting cardiology or cardio-oncology involved for a patient that has perhaps a significant cardiac history, or for a patient that's on BTK inhibitors now and is beginning to develop some of the cardiotoxicities.
Thank you, Lisa, for that comprehensive discussion of the risk profile of BTK inhibitors, the role of the nurses as well as advanced practice providers, and working with the interdisciplinary team in the management of these patients. It is really very helpful for us clinicians, nurses, as we work towards the management of these patients, and the information is most valuable. Thank you so much.
Thank you.
If you want more education on BTK inhibitors, visit the ICO's website at www.ic-os.org or the France Foundation education page at www.francefoundation.com/education. This resource was developed by leading experts from ICOS and the France Foundation to support providers and patient care. Tune in to other episodes in this podcast series, where experts discuss the use of BTK inhibitors in CLL and how to assess and manage the associated cardiovascular risk in patients with CLL.